The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we'd like to welcome you to this morning's Safe and Calm webinar. It's now been almost 3 months since our first stay-at-home order, and while things are slowly reopening, we still see some real challenges in terms of providing for our seniors and also working within some really confusing guidance at times. Today we're going to provide a few general updates since our last webinar earlier in the week. And we're going to spend a lot of time talking about visitation and reopening for different provider settings with a focus on independent living, since that has been so confusing to a lot of people. We continue to look for guidance from the governor's office about that. We hope to get some clarifications in the near future. And then we're also going to spend some time toward the end of the webinar so that persons who are not nursing home related can jump off if they want at that point. We're going to be talking about the nursing home CON. And for both of those last topics, we are very pleased to have Phyllis Adams from Dykema Gossett with us today, and she's going to provide a legal perspective on some of these issues. So this morning we're going to start with some general updates, and I'm going to turn it over for a very brief legislative update to Dalton.
Good morning, everyone. Thanks for attending today. As always, the handouts are available in the GoToWebinar tool in PowerPoint and PDF form. So if you need to access them before you leave today's call, please do so. We'll also be sending those out at a later time. Since Wednesday's call, it's been pretty eventful in Lansing. Senate Bill 690, which is the one that appropriates the CARES Act funds, has received $800 million in additional funding to it in the House of Representatives. For long-term care providers, this means that a grant was established to refund providers for their PPE and testing costs of $50 million. This $50 million fund can be accessed by all of healthcare and all healthcare providers. So we feel it's a rather small fund for all of healthcare, but it is something. And this is also the Senate bill that provides $226.5 million for direct care worker payment increases. This is at $3 an hour for workers who work in SNFs. It was meant to fully pass the House yesterday, but it did not, as the governor signaled that she would like to negotiate. Previously, we had expected this bill to be dead in the water because these CARES Act funds are at the sole discretion of the governor, and the legislature was trying to spend money that they don't actually control. The governor controls these funds until June 30th, and right now she's lobbying the federal government to remove restrictions to let her backfill the budget shortfall with these dollars. And the negotiations that took place Wednesday night broke down within a couple of hours. So they're going to try again this weekend, but we'll see what happens. If this bill is going to pass, it's going to look very different than what it does today. Just a brief update on Senate Bill 956. This is the Senate bill that disallows nursing homes for admitting or retaining COVID-positive residents and forces the department to create 8 centralized care centers across the state, 1 in each HSA. Currently, it was introduced on Wednesday, like we were told and what we were expecting. But the legislature does not want to touch this bill because they're looking to be cooperative with the governor and the administration, looking forward to the budget negotiations. And lastly, I don't have a slide for this topic. It came up recently, but Leading Age National is looking for stories for those who partake in HUD-assisted senior housing. They're looking for any information, stories, paragraphs regarding your COVID-19 expenses and experiences. They feel that there seems to be some level of disbelief on the national level that providers are actually spending money to protect residents and staff. And so any stories they can have will help make their advocacy even more stronger. They did want me to note that all of these stories will be de-identified, so you can feel free to speak knowing that no one will know who you are and there won't be blowback. If they will ask you if it will be okay if they mention you, if they get follow-up correspondence. So that's kind of what we're looking for there. And if you do have any stories, you can feel free to email me. My email is dalton@leadingagemi.org. That's DALTON@leadingagemi.org.
Well, thanks, Dalton. Moving on to some general updates. We do see that the National Guard, who was supposed to have ended their tour of duty here last week, has been approved for several more weeks to help with baseline testing of nursing homes and I believe assisted living as well. They are doing these baseline testing assistance at in groups in counties, in groups of 10 counties. And next week they'll be starting in Iosco, Clinton, Mason, Monroe, Jackson, Branch. They're all listed there. St. Joseph, Van Buren, Sanilac, Ionia, and Cass. As they move out to more rural areas that have fewer cases, they might stop prioritizing these based on how heavy the caseload has been in those counties, and they might start going to a regional thing. But at this point, I would say they have completed way more than half the state. We've had a lot of questions the last couple of days about testing. I want to remind everybody that the CMS guidelines for testing and for reopening are only recommendations. So even though we anticipate that a lot of those recommendations will flow into whatever the state plan ends up being, those are still not absolutely required. However, this baseline testing piece is an opportunity to kind of get ahead of the game and to use state funds to support that, because there is going to be some testing requirements coming down the road. Lots of questions about whether or not people can refuse. Yes, you can refuse. I think that as a facility, if you refuse now, you're really missing an opportunity to, first of all, have the state fund it, and to get ahead of at least whatever testing requirements are definitely going to come down the road. Residents can refuse. Staff can refuse. However, facilities can make it mandatory for staff, and we talked a little bit about that on Wednesday, and there are some, supportive resources available to that can speak to that. We put them in our Q&A guidance on Wednesday. Another issue is that some staff have tested positive, have been isolated for a long time, but they keep coming back positive, and that's not an unusual situation. I've heard that story many, many times. But we also want to remind everyone that the CDC does not require testing-based strategies for return to work. Symptom-based strategies are okay. So if you meet the CDC guidance for symptom-based strategies, which is 3 days since all symptoms have gone away and 10 days since the first appearance, you can let people who are asymptomatic back into your facility. You don't have to retest them. And sometimes I think it's better not to retest anybody who's tested positive and who is doing well. Otherwise, it just complicates things, and it's an additional cost as well that I'm not sure that everybody will want to bear over time. But anyway, so that's our update basically about testing. There is a new FAQ that was updated on June 3rd about the provider relief funds. And I have to tell you that I am not an expert in the provider relief funds, so we just wanted to make sure that you're aware of that. We will send out the link with the Q&A. The CDC has also updated their guidance a little bit for assisted living. I did review this guidance. I didn't find a whole lot that was particularly surprising in it. It's mostly the considerations that should be made in order to reopen assisted living. But basically, the main changes in the guidance is that they speak to the fact that the state is going to make these decisions, especially for assisted living, because there's no federal requirements for it. Excuse me. And also, they refer to the nursing home guidance as pretty much the standard for thinking about reopening assisted living as well. The CMS nursing home reopening guidance obviously doesn't technically apply to assisted living, but I think that there's a CDC recommendation the states think about it that way. So if you have not seen the CMS reopening guidance, it is on our website. I will put it again in the Q&A if you haven't reviewed it and want to do that. So that ends our very brief update for today before we move on. Are there any questions?
All right, I do have a question, but before we get to that, Leading Age Michigan would like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference, despite it being temporarily postponed. We look forward to your continued collaboration, and we remain grateful to you. Make sure that you can support their services when you guys need them. All of these people are very important to us and great business partners. Now, for the questions, in independent living, can we require new move-ins to provide proof of negative test? Can we require any move-ins to 14-day self-isolate?
I think that's a legal matter. I'm not sure what the rules are for that kind of housing issue. I think that, why don't we hold that question until Phyllis gets on the line? I think that Phyllis would probably be better at answering that. And I do want to talk about independent living a little bit before we get to those questions.
Okay. Did you want me to go ahead and unmute Phyllis now, or just wait on that?
No, wait on that until we get to that topic.
All right, sounds good. Also, we don't have any other questions, but we will have a provider relief fund training coming up with Plant Moran on June 18th, it looks like, on June 18th from 12 until 2 p.m. Eastern Standard Time, and there will be more information coming out on that shortly. So make sure just to check back on our website, leadingagemi.org, and in the events calendar, and you will see all that information. Other than that, I think we are good to go, and we can move on.
Great, thank you, Blake. It's good to know that Plant Moran's going to be doing that training. Social isolation, that's the topic that we really want to think about as we look at some of the issues facing our seniors during this pandemic. We have been talking to the long-term care ombudsman a bit in the last few weeks, and she's really cited a lot of concerns and problems with how individual residents are responding to the restricted visitation and other requirements kind of mandated by the pandemic. Many are not eating, they're losing weight, they're developing behaviors, they are simply not thriving at all. And so there are some real concerns here about how to best serve our residents as things evolve. But then, of course, there's a balance. We have to also look at the fact that Michigan is number 3 in the nation in the proportion of deaths from COVID per 1,000 residents. And that was data that was put out in nursing homes. We don't have data for anything but nursing homes. So the risk is very real at the same time in some of these congregate settings. And that kind of adding to the problem is that we really don't have information about the spread of infection in any other residential settings other than nursing homes. So we don't have a real good sense of what's really happening and what needs to be done. In fact, some people believe that the nursing home data itself is underreported. So it could be even a larger problem than we know. So there's real concerns about how some of our residents will be able to spend their last days and their overall well-being. So our plan is to spend the next few minutes getting some input about the isolation and visitation issues, and then we will ask Phyllis to jump in and provide some input as to any risk or legal concerns. So we're going to start with independent living. And basically, we'll be talking about Executive Order 2020-108, which includes the visitation restrictions and the screening criteria for nursing homes, adult foster care, homes for the aged, assisted living, and of course, independent living. So a major point of discussion and opinion is what's the definition of independent living? What facilities would fall under that definition? We've tried to get a good answer for that, but we've not so far. And there are work groups now at the state who are working on these issues with the governor's office and with the state departments themselves. So the governor has called on licensing and regulatory affairs to address reopening considerations for all senior settings. And this, of course, further emphasizes the need for some definitions here. One of the groups working on these issues has identified a set of questions about what constitutes independent living. And they're listed for you on the slide. Is it senior apartments with service coordination, transportation, congregate dining, group activities, rented space to home care, or any combination of those? So they have set these questions to the governor's office for some response. One of the things that they have noted is that the Detroit Housing Commission apparently considers these senior communities as independent living. Their senior communities as independent living. So although we know that there are a lot of different views out there, we'd kind of like to hear from you all about who you think might be included in this category and whether or not you consider yourself, and you have to define, your service package, but whether or not you consider yourself independent for the purpose of this order. And I'm hoping that we have some of those members online this morning. So let's take a minute and hear from them.
All right, I will give it just 1 second in case anybody is typing. I haven't seen anything come through quite yet. Yeah, Barb, anybody can chime in at this point. We'll give it another 15, 20 seconds, 15, 30 seconds, something like that, in case anybody is typing up something big. If not, we will go ahead and continue moving on. All right, hold on. I will actually, so Barb Giles says that she has something to say. So I'm going to actually unmute you really quick, Barb, and you can be heard now.
Yeah, okay, thank you. So we have been struggling with this just like everyone else, but we have really been erring on the side of conservative action and have been following along for our independent living as far as 2020-108 and several of the other orders are considered. We have been following it for our independent living, erring on the side of being conservative and waiting for further guidance that might be helpful in the future. But it is challenging to continue to follow something that you're not 100% sure you should be following or not.
Okay, thanks, Barb.
Thank you for that, Barb.
Anyone else?
I will go ahead and mute you back, Barb. So somebody said, we consider ourselves to fall under independent living and have been abiding by the EOs, do not offer home care, but do offer congregate dining, group activities, transportation, and 24/7 security.
Okay.
somebody said, how do these rules relate to wanting to show or renovate an independent living unit in a life plan community?
Show or renovate. I don't think that there's any problems with taking new persons on, as long as there's some, there's no stay-at-home order anymore. And certainly they are, obviously this is a gray area, but certainly there are admissions and discharges from other settings that are still being isolated. So I would think that with social distancing rules and some careful pieces, you should be able to admit.
Sounds good.
If that makes sense to you.
All right. We offer support service packages and congregate dining to independent living residents and consider our community to fall under the definition of independent living. We have included our IL residents in the guidance for our AL and MC communities.
Okay. Okay, great.
All right, and that is all I have now, so we will move on.
Okay, let's move on. So, if you're an independent living provider and you haven't considered, well, if you're, let's say, a senior housing provider, and you haven't considered that you should fall under this independent living provider category under the executive order, have you made changes to visitation and worker screening? And how significant have the impacts been to your residents? That's one of the issues that is got to be put into balance, because it is true our residents are being affected by this. One of the issues is that social distancing is still required. So do you think that if your facility is completely open, you could effectively maintain social distancing? And if you were thinking about safe reopening, do you think that the rate of community transmission in your area, or if you're aware of cases in your facility, I know a lot of providers may not be aware of that, but are those things that you would consider? So these are just some ideas to throw out there. I do know that we have had some members that do not believe that they should be covered under this category. So I know that this has been a challenge. Think about some of these questions, and we would like to hear some of your responses.
This is also just an add-on from the last thing. Deanna, they said, we have also prohibited visitors to our independent community. These residents are housed in the same building as our assisted living, HFA exempt.
Right, right. And that's a big issue, that if you are especially tied to, a campus that has more than one setting, level of care, it would be difficult to think of yourselves differently as an independent living provider.
All right. I am not seeing anything come in, so did you just want to move forward then?
Let's give it another minute just in case.
Okay.
What I'd like to do is, as we're waiting, why don't we hand the mic over to Phyllis for a few minutes, and she can give us a bit of her perspective on all of these issues around the independent living side.
All right, give me 1 second. And Phyllis, I'm actually going to read this question really quick, and then I will unmute you. It just came in. It said, we have not made any changes at this time. We have supported residents by implementing a staff buddy system with daily check-ins for all independent residents. Also, Zoom meetings with families. The local community has been amazing in their support with free ice creams and other treats. The residents are doing remarkably well. We have a MSW on staff who is monitoring closely.
Okay, well, we would like to hear stories. First of all, we'd like to hear stories that the residents are doing well and that the community is pitching in, but we also want to hear stories, and feel free to email us, of residents who are not doing well, because I think that has got to be in the discussion when the governor makes some further decisions. So if we're ready, can we turn this over to Phyllis for a bit?
Yes, I am going to unmute you right now, Phyllis, so everyone can hear you now. You're all set.
Great, thank you.
Can you hear me?
Yes.
Yeah.
Okay, great. Good. Well, thank you, Deanna and Blake for getting us this far, and also Dalton for the legislative update. So just a couple observations about this visitation prohibition. You know, I think we're going to see that the ramp up to this COVID emergency, where we had these emergency orders, it was very confusing. We're going to see that the ramp back down is just as confusing. I think that's what, as this starts to lift, and it's lift partially, there's going to be a whole variety of different issues. Some of these are definitional, as Deanna pointed out in her comments about Executive Order 108, which again runs through June 26th at 11:59 p.m. So we have a way to go under this visitation restriction. And it really, in the independent living situation, independent living, as everyone knows, is not a defined term. So are you in, or are you out or not? I appreciated the summary of the factors that were there in terms of service coordination, transportation, congregate dining, those things. But I think an important consideration is, how do you self-identify? If your agreements with your residents say independent living agreement or independent living residency agreement, I think you're going to have a hard time saying to someone, well, we're not actually independent living, when you have self-identified as independent living. If you have, for example, we had a conversation with a housing provider that they're just a housing provider and their agreement says lease. So it doesn't say independent living. There might be some elements there where there might be some things on the campus. They're not mandatory. It's not a package. It's not package pricing. It's kind of a la carte. You pay your rent. It's really rent under a lease. It's a more of a traditional landlord-tenant situation. Then I think you have a better argument that you're not an independent living facility. But again, this is difficult, and it's particularly difficult because we've been continuing to keep our eye on the litigation ramifications here of getting this wrong. So you end up saying, well, we didn't think we were an independent living provider. We lifted our visitation restriction, and then we ended up with 3 or 4 COVID cases and someone died. I think we just have to be very cautious about how we're doing this, just because those are issues that we don't have any precedent for this, except we know already the litigation is starting to crank up, and it would be very easy when you have a policy that is applied across a facility and multiple individuals are impacted to try to get to class action status under that kind of a scenario. So I think this new realm of litigation makes it interesting. Even if you are in the category where you think you can defend that you're not a quote independent living facility, your agreement doesn't say that. You don't have kind of these other packaged components that are more activity with daily living support or amenities. I think that you still are probably going to need to put in place some social distancing policy, or at least put something out there reinforcing the governor's social distancing orders and orders in terms of face coverings. But then the question is, okay, well, we did that, so we weren't negligent in failing to inform our residents of the need to continue to comply with this, because you think of this as confusing for all of you folks who are in the business of running senior housing and senior facilities. The individual residents, I think, have no idea what they're supposed to be doing right now. So if you decide you're in that category where you are not an independent living facility, you're a housing provider, I think you might still circulate the governor's order. Just make sure people understand those. I think you have to be careful about policing that. Once you get into the job of policing, then the question is going to be, well, did you police all the time? Who didn't you police? Is that going to end up running into some rights issues for individuals? So I think at this point, my position is, and we haven't given this a lot of thought, but I think probably put the information out there, but we're relying on people to self-police. If you end up with a really egregious situation with somebody who's just refusing to comply with some of the requirements, then you may have to deal with that in an individual capacity, perhaps through trying to educate that individual about the fact that community spread is still out there, this is still a threat, they're putting other people at risk, those types of things. If you're actually going to make a housing decision based on that, then I think you need to talk to legal counsel, because that could get you into some hot water. Just to go back to one other issue about kind of showing independent living units, I think if you are an independent living facility under this, lack of definition, but if you characterize yourself that way, your agreement says it's an independent living residency agreement, then I think there is a concern potentially about showing or renovating that unit. We've posed this a couple of times to the state. We haven't been able to get a response back saying, we agree these people are not visitors that are subject to the order. They have told us that they think we need to continue doing the virtual showings. Once somebody's actually signed a residency agreement, then they're not a visitor. Then you can say they're a resident. But up until that point, if you're still showing the unit that they haven't become a resident, then I think they are a visitor. Movers are potentially visitors. And there's no definition of visitors either. So the other problem we've had is, how do you move, for example, a decedent's personal effects out of their apartment so it can be vacated and then cleaned and renovated for the next resident if you can't get movers in there. So that one's a bit tough. We've also had the question of, what if you have construction that you could work on by accessing the facility from the perimeter? You can go in through a window, seal that off on the inside. That seemed like an easy case to me, but I put that to Lara, and I have not been able to get a response from them as to whether they agree that that's not actually visitation, because you're never inside the building. You're coming in through a window, working on a room that's being renovated, and then the workers are going back out through that window or other construction access where they're not actually coming into the building. I think there's a good argument there that that's not actually visitation, because you're never within that part of the facility where the residents are located. And this is going to become even more difficult with the warmer weather. Is it visitation if someone comes up to the window? Is it not visitation as long as the window is closed? What if the window is open? Then you have to maintain a 6 foot socially distanced space. Does that still constitute visitation? So again, we're starting to get into these questions of what's actually the facility. And I think the right argument or answer here is the facility is the interior perimeter. If you're on the outside of that, you're not actually visiting, and particularly if you're maintaining social distancing or the window is closed. But I think there's a whole minefield of issues there for providers. And with that, I know DI has a lot of information, so unless people have questions, I'll conclude my remarks.
Thanks, Phyllis. I think that's a great perspective. So does anybody have questions for Phyllis about the independent living piece?
There is one question. It came up during, I believe it says, at the safer at home or as the safer at home order was lifted, the challenge to control visitors and social distancing has become very challenging. Independent living residents are allowed to leave the building, and now they can go to stores and restaurants. It makes it impossible to control our and their exposure. Other than that, I am not seeing any other questions come through. Oh, actually, just had one. Right. Sorry, I just had two. It popped up really quick.
Well, let me respond, Blake, to the other first. That really has been part of the scenario that has been driving a lot more concern about visitation and restriction of that for independent living providers, is because the seniors consider themselves independent persons who can come and go as they please now that the order's been lifted. And we have addressed that with Robert Gordon, who's the director of MDHHS last week. However, we also heard from Dr. Caldoun that her feeling is that the risk is still so high that seniors should stay at home. So we still get conflicting messages a lot, and we have forwarded all these pieces to the state. We do hope to get some definitions and some conclusions shortly. But until then, I think, and I think Phyllis would agree from her perspective, is that, you need to consider your risks here. So you have another question, Blake?
Yes. All right. So it says residents want to leave the campus to visit with families. What are your thoughts on asking that resident to self-isolate for 2 weeks?
I don't know, Phyllis, if you have a thought about that, but I have kind of encouraged that only because there is still a visitation restriction in place. And once a senior moves out of the facility and moves around the community, they almost they've been out in the community just like any other visitor when they come back. Now, I don't know what self-isolation would look like in an independent living setting, but I do think that it's a consideration that you might have to look at, or some way to ensure that safeguards are kept. I think that when the stay-at-home order was in place in other settings, if someone needed to go to a physician, if someone needed to go out for something, they were self-isolating for 14 days when they came back. And considering that, these are group settings, you have to look at your risk and make a determination. There is no hard and fast rule for independent living about this. But, again, I think you need to look at your risk. So let's move on, Blake, to the next slide. We're going to talk briefly.
I was just going to say, I have quite a few more questions that came through.
Oh, okay. All right.
All right. So as a life plan community, are we better waiting for the June 26 restriction to be lifted before allowing vendors and prospective residents on site?
Allowing them on site?
Yes.
I would say yes. Yes. There are visitation rules for all of those levels of care until June 26th, unless, she changes it before then. I have always thought that the risk to seniors is so high that you would have to comply with that if you are an independent living provider, as well as, the higher levels of care.
Okay. As we start to reopen independent living, are there any concerns with allowing residents to gather in groups less than 10 and opening group dining this upcoming Monday with limited numbers?
The group dining I struggle with because the CMS restricted communal dining very early. But then they came back and said, well, it doesn't mean that you can't have people in the same room. It just means you need to be very, very careful about it. You can put people at separate tables 6 feet apart. You need to make sure that people aren't congregating together, that you're not moving one person back and forth among people to help feed, or whatever those issues might be. CMS put out some guidance about kind of how to do communal dining. The problem is that for the other settings, we don't have a CMS rule. And for AFCs and HFAs, Laura came out and said you can't do any communal dining. Now that doesn't impact independent living, and I do think that the CMS guidance for that would certainly be appropriate as long as you take care. And we can put that, if you're not used to the CMS guidances, we'll put that reopening guidance out on the Q&A for your review. Because even though CMS obviously doesn't regulate anything that we're talking about other than nursing facilities, a lot of the other provider types are going to be covered by a similar set of requirements, and the CDC does that as well. They provide a similar set of requirements to all the settings. So we can do that, but I would think that you could look at congregate dining with some careful precautions.
All right. And then this one is directed towards Phyllis. It says, Phyllis, we have continued to restrict visitation in our independent living, but are considering allowing outdoor visits for independent living and assisted living while maintaining social distancing and wearing facial masks. Do you think this is okay?
Yeah, so I don't know if am I off mute?
Yeah, you're good.
Okay, good. So yeah, so that's interesting. That gets back to the position that I would like to take on this is if you're outside of the building, you're not actually visiting. So the question is that actually going to be permitted or not? Obviously, the risk of transmission based on the science that's been posted is less when you're in an outdoor, highly ventilated space. The risky places are indoors. So if it's outdoor, people are spread out. Is that actually visitation? We don't have an answer for that, unfortunately. So again, it's in that gray zone of, I've been trying to get the state to define what's visitation to see if we could get some outdoor activities that are kind of in the clear zone, just to make it a little bit clearer for people as they're trying to improve the, daily living experience for the residents. So it sounds like it would be relatively low risk, I think, which is important from a risk management standpoint, because you don't want actual transmissions for litigation reasons and obviously for the safety of your residents. But in addition to that, I think you could also try to defend that it's actually not visiting the facility. The people are outside of the facility and they're socially distancing, and that's permitted under other Michigan orders. Now, the one thing, just going back to the communal dining, that issue is just to remember that communal dining prohibition under EO 2020-95 runs through June 17th. So we do still have some restrictions there. As Deanna said, nursing homes have that CMS guidance, but we haven't really seen anything from LARA implementing that as a state licensure policy or adapting that to licensed assisted living either. So, my advice has been that communal dining, and there's a debate about what that means, and you could look to that CMS guidance and say, well, it's not communal if you're sitting 6 feet apart, or you're so distant that you're not actually kind of dining together. You happen to be in the same room, but you're separated. There may be some creative interpretations there, but we have not seen anything from LARA actually endorsing or adopting those. So there's some risk on those issues as well because of the ambiguity there.
All right, sounds good. Thank you very much for that, Phyllis. I believe that concludes the questions, so we will go ahead and move on.
Thank you, Blake, and thank you, Phyllis.
Hey, Deanna, should I mute Phyllis at this time or keep her open?
You can keep her open,
Okay.
Blake. Yeah, keep Phyllis on.
Okay, just letting you know, Phyllis. So.
Okay, the next two slides are really similar ideas, and I'm not going to go through the same set of questions. I am wondering a little bit whether or not assisted living providers are testing yet. I do know that there was a work group in the state that was looking for the same baseline kind of testing in assisted living, and I'm not sure if our members are feeling that yet. I do know that reporting for assisted living has started. We haven't seen any data yet. But I guess for assisted living, in the next slide, I talk about nursing homes. What we would really like to hear is the impact on the seniors. I think that we hear from one or two members who have concerns and issues, but we don't have a sense about how broad some of the problems are. So I think that in our Q&A that I send out, we will ask for some input about how you feel your seniors are responding and reacting to the social isolation that they're feeling, because we would want to take that with us back to the state as well as they're considering the reopening guidance. So go ahead, Blake, move me 2 slides forward. So we're going to end our session that discusses anything but nursing home issues. So if you are not a nursing home provider, then you might want to consider jumping off at this point. We would like to get some input about CON in the next few minutes. So if you are a nursing home provider, we hope that you stay online.
All right.
And Blake?
And then I did have one thing come in, but before that, each year, Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. Here is a list of half of the business partners who have stuck with us through these tough times and will still be with us at our annual conference when we do get that going at the trade show, and then the other half will be near the end of this PowerPoint. Someone said the impact on our residents has been significant.
Okay. We will send out kind of a request for information, if you would, to find out, how many facilities are really struggling with this and how many consumers are really struggling with this as we move forward.
And then one other person said something as well. They said our seniors in assisted living are struggling with the lack of contact from friends and family. We have started to allow some visits if they are deemed medically fragile, which have helped.
Okay, great. Thank you.
Yeah, this is Phyllis, and I just wanted to mention, I think that's another way to exploit this visitation restriction, because it does have that provision in there that allows visitors for the provision of medical care and the supportive activities of daily living. So if you can find a way to kind of clinically justify this, that it's a mental health issue, and try to document that, then I think you could try to come up with a safe visitation encounter for that resident to try to address that issue by tying it to supportive activities of daily living and or a medical issue.
All right, thank you for that, Phyllis. And that is it. So I think we can move forward. So let me go ahead.
Move on to nursing homes, yes, please. So a few brief updates before we get into CON. QMI surveys, the resident surveys that are required for your QMI supportive payments. The due date for those have been extended 30 days out to September 18. The department told me yesterday that they hope to get a letter out next week to all providers. So you do have another month in order to get those resident surveys in. One of the things that we have identified that last week the governor rescinded, you'll have to forgive me, I think it's 2020-82. She rescinded several orders at the same time, and 2020-82 included a whole range of flexibilities that nursing homes could use to deal with staffing. And so the flexibility to get assistance from ancillary staff with feeding, communal dining, transporting is now prohibited, and a temporary CNA registration was also prohibited. And considering that we are very much under a strain in terms of staffing, we thought that this might be a little bit premature. So we have reached out to the department to kind of assist us with this, because these are things that I think that could have helped. And actually, Dr. Gordon, when we spoke with him earlier in the week, was talking about ways to support staffing. And then at the same time, the EEO is not helping. So we do hope to get a response about that, and we do hope to see something from the state in terms of an emergency staffing plan, which apparently they're working on. Also a reminder that SNF reporting to NHSN, the grace period ending on 5/31. If you are still having trouble getting enrolled, you need to talk to the CDC. They are still trying to work through some enrollment problems. And I'm sure that everyone's probably aware that the nursing home national data was published yesterday on the Nursing Home Compare website. It will be updated weekly. There's a 2-week delay after this first posting, but then it will be posted weekly. With 88% of facilities reporting, there's 13,600 reporting SNFs. They found about 95,000 cases of confirmed COVID and almost 32,000 deaths. They do remind everyone that this may not align with state data. Michigan has completed 368 of its on-site infection control surveys of 442, which is about 83.3%, but only 152 are posted right now. So we're looking for that data as it comes out. So just to let you know how Michigan fared a little bit in terms of COVID, we are number 6 against the nation in terms of resident cases per 1,000 residents. And you can move to the next slide, Blake. Unfortunately, we are number 4 in the resident average deaths per 1,000 residents. So that's pretty high. And considering those issues, you know, safety, the safety balance is a hard question as we move forward. If you haven't seen the website, you might want to try to take a look at it. It has this interactive part where you can put in a city, state, I think maybe zip code, I'm not sure. And a map will come up of that area, and all these red dots will appear where there's a nursing home. You can just click on that dot and your nursing home data will come up. I put Woods Haven here. Remember that the data is a few days old, so if you've had some changes, it's not accurate. But you can look at nursing homes and your nursing home and nursing homes around you as well. This is the nursing home compare map about how we fare in terms of total residents with confirmed cases, and you'll see we're in the higher level group. Just want to remind everyone that there's a June 30th deadline for requesting civil money penalties funds for telecommunications. I put the links here again. You can't get to them through the slide, but we will include them again in our Q&A. Okay, now to the heavy stuff, the bed need methodology. I think everyone's pretty much aware that last fall, they updated the numbers using the old bed need methodology and came up with, I think, a net increase of I don't know, somewhere around 7,000 beds, which, you know, freaked everyone out, to be honest with you, considering the fact that utilization in some of these areas and current occupancy is pretty low. So the Standards Advisory Committee has been working for the last 6 months on a new bed need methodology. We do know that they added also an 85% rule in order to kind of minimize the numbers of possible beds in the interim. Currently, the bed need methodology calculates a utilization rate based on age groups. So like 0 to 64, so many persons per 100,000 people, 85 plus, so many persons per how many people. But they do it for the state. They do it for the entire state. And then they take that number and they apply it to each county. And that's where a lot of the problem is because there's a lot of variation in how people use nursing homes across the state. So they applied that to the county. And then they simply took that, multiplied it by what they expected the population would be, and that would be your bed need. They would adjust it for occupancy with the idea that nobody's ever 100% occupied all the time. So that's the current methodology, and it seems kind of simple and straightforward, but it added to problems over time. So, and this is kind of the succinct version of what the methodology is. So the proposed version goes ahead and calculates the utilization based on age group, but it does it for each county. And then on top of that, because the counties are not necessarily, they're arbitrary, really, if you think about it. And how the nursing homes are spread out in the county is arbitrary. It's not, there's no plan or design to it. So it's possible for someone to frequently cross county lines to get to the closest nursing home. So because of that, they take the utilization for a base year based on age by the county, and then they compare it to a larger health service areas. Now, health service areas are these fairly large regions in the state. They're defined by the feds, and there's 8 of them. So when you look at the county-based utilization and you adjust it for what's going on in the larger area beyond them, it kind of dampens some of the real high and low levels of utilization. Then it applies the adjusted rate to each county's proposed population, multiplies it out, and then adjusts for 90% occupancy. So it seems like a little change. It actually required a lot of mathematical work, but this is what's being proposed at this point. So the advantages. No longer applies a statewide average to the counties. It adjusts the current rates by comparing to HSAs, and it still adjusts for 90% occupancy. And when this was tested, they tested it by pretending that 2018 was our year that we were going to project to. And so they went all the way back to 2013 and looked at the data. So this method, of many of which we looked at, this method did a really good job of predicting the real bed need. Now, it's not perfect. There are no methodologies that can be perfect, but this is what the commission, the committee, the Standards Advisory Committee will be working and approving next week, and then it will be a recommendation that goes to the commission. So we wanted to give everyone an opportunity to think about it a little bit and see if they have any input. And Phyllis, do you have any thoughts about this?
No, thank you, Deanna. That was a very good explanation of something that's not very easy to explain. You know, I think the bending methodology we've had has been in place for a very long time, and, you know, they did the best they could at the time. They do use a geography expert now who has helped with some of the other standards to come up with these methodologies. So we don't know, this will be more predictive, but it might be. The only question I have is whether there was discussion about adjusting occupancy for 90%, whether that should be 85% or how that would impact the numbers, given that's kind of the Medicaid occupancy threshold requirement. So I was just curious about the 90 versus 85.
I'm not sure I understood all of that, but the 90% piece, and were you talking about the 85% rule?
Yeah, the Medicaid 85% rule in terms of occupancy before you have a kind of a reimbursement penalty. So that's kind of out there. It hasn't been a CON concept, but I was curious if there was any discussion of using 85% instead of 90%, which frankly is just a historical carry forward from what's been in the methodology. I'm not sure what the science is.
Well, it has been discussed, but perhaps not in the way that you're referring to. A lot of the drivers in the group wanted to get rid of the, when they were looking only at use, they only wanted to identify use rates, occupancy rates, and not even by cohort. That was the original plan. And they wanted to get rid of the 90% occupancy adjustment here, which we fought to get back in because no one can be expected. If you only have so many beds, and if you're expected to keep 100% occupancy all the time, that doesn't work. There was some discussion about how they relate, and I think that there's some very opinion about that. In my head, this is about how well you're able to keep your building full in order to adjust for beds. And the 85% rule in my head is really about how you can spread, the appropriate way to spread your support or administrative costs. So to me, I have not related them, but other people have related them. But I don't think that there's any good answer out there right now. We decided that 90% occupancy was a reasonable amount to figure out whether or not that most facilities should be able to keep that in order to determine what the number of beds are needed for each planning area. Does that make sense?
It does. It just seems very high to me because I don't know how many buildings actually achieve 90% these days. But again, I'm not quite sure how that impacts the numbers.
Well, it isn't that we expect them to get 90%. It's not based on payment or anything. What it's based on is if we identify that this county needs so many beds, are we going to give them more beds? This is just the idea that they don't need any more beds if they can meet the 90% occupancy rate. I'm not saying that very clearly, but okay.
No, I understand.
Okay. Anybody else? Any comments from anyone else online?
Someone said, what is your opinion on the impact of competition?
I think that for most areas, this will keep competition down, actually. There are some areas, as there are currently, that have some bed need. Most counties are overbedded in the old, looking at the really old numbers, not the current changed numbers that they did in the fall. And without knowing what the real utilization changes that are coming down the pike for nursing homes are, I think that it's a pretty safe way to limit the number of new facilities in areas that have not the highest utilization already. Most of the areas that we find that need beds using this methodology are rural. So the competition should decrease with this in that respect, if that's what you're meaning.
All right. And then I had one other thing. It said, looked at the NHC website, not easy to find the info. Am I missing something obvious? Our first COVID survey is listed, but not the second.
Can you repeat that? I didn't get the first part, Blake. I'm sorry.
No, you're fine. Looked at the NHC website, not easy to find the info. Am I missing something obvious? Our first COVID survey is listed, but not the second.
Right. Okay. So remember that not all the surveys are even posted. I would say not even half of the surveys that were done in Michigan are posted yet. So when I was looking at the data, yesterday when it came out, I was reviewing some of the citations. I did note that there was only 152, and they've done well over, probably closer to 400 than to 300 surveys. So that's true. And I did have to wander around a bit. So, it is something that you're going to have to play with. But if you can't find something you need, just shoot me an email and I'll work through it with you.
All right. Thank you for that. I don't have anything else, so it looks like we can move forward.
Okay. So this next part is what I consider the hard part. And I've included these definitions here just for your review later in case you need to be reminded about what some of these things mean, because they're not intuitive for me at least. You can move to the next slide. Like this piece is what we're calling the 60% rule. And this was proposed by the Department, actually, of Health and Human Services to, I think, address the overbeddedness that is in some areas, because the bed methodology stops from adding beds. It doesn't do anything about places that have a high concentration of nursing homes and has limited occupancy throughout. And also, some of their concerns is that some of the facilities with low occupancy tend to be the poorer facilities. And I don't mean poor in terms of money, I mean poor in terms of performance, and also could be money as well. So I don't want to go through the hard details with this because this is a lot of language as well. But basically, for replacement beds or adding beds, if you have an application coming forward that and you have an occupancy of less than 60%, you're going to have to get rid of your beds in order to move it up to 60%. And for those two scenarios, they will use a 3-year period of review. For relocating beds, it's a very, very similar thing. The receiving home must have a 60% average occupancy for 12 months after the relocation, and you have to get rid of your beds down to a 60% occupancy rate before you do it, based on the past 3 years of data. Some of the requirements use 12 months immediately prior to the application, and some use 3 years. You can move to the next slide. So if you want to acquire a nursing home or renew a license, it's the same thing. This is where you can use the numbers for a consecutive 12-month period. But basically, you have to give away your beds if you don't have a 60% average annual occupancy rate. The project delivery requirements, the average occupancy for all licensed beds has to be 60% for the second 12 months of operation, or beds must be reduced. So this is kind of a dramatic change, and I guess I would like to ask Phyllis if she has any thoughts or considerations about this.
Well, yeah, these are pretty big changes, because one of the concerns we've always had with the CON program is they put rules in place, but there's really no penalties if you don't end up complying. The other problem is that in Michigan, you were approved under the CON standards that were in effect at the time your building was approved. So if you haven't had a CON event in the last 10 years, these standards are not going to impact you. So you don't need to be worried that, uh-oh, I'm going to have 60%, or this change is going to end up impacting me. These would only be for new applicants that come under these standards. It will not apply to those folks who already have a CON to operate, or perhaps had a CON to add a wing or de-densify their building by replacing their beds into new space. Whatever standards were in effect will apply to you at the time of your CON. So that's just one point. Other than that, I can understand the department's concern. There's a lot of phantom capacity out there that isn't, real capacity. It's not staffed. They're just beds, but they're not actually staffed beds. So I think, again, there's been some concerns. I'm not surprised to see these restrictions. And frankly, this would help the bed need methodology be more predictive, because you would then end up having something that works, because this unused capacity will end up coming off the books and those beds will go out of existence.
Right, right. Okay.
I did have
we
one
can
question.
Move on to the next. Okay, good, because I was about to go to questions.
All right. Can you offer an example starting with a 100-bed facility? Who do you give your beds away to?
My understanding is that you are returning them to the state, and they will not go into the pool if you're in an overbedded area. This really only impacts facilities that are requesting CONs in an overbedded area.
I agree with that, Deanna. So they just go back into the bed pool. You'll just have to say, and these kinds of provisions are in some of the other standards for hospital beds, for example. So if you want to do certain things, you have to relinquish those beds. They go back into the bed pool, but they're not available to anyone if it's overbedded. It just makes the planning area even more overbedded. Because instead of being 20 too many beds, if you had to relinquish 40 beds, then it would be 60 beds too many. That no one can apply for those because there's already enough license capacity to meet the demand.
Right. Well, and what's probably, I don't know that there's a lot of support for this. And in fact, I think the department is considering kind of backing away from it a little bit, mostly only because, not because of the whole idea of it, but because the COVID crisis has messed with occupancy so much. They're not sure that it's going to be a fair piece, but they could write, some sort of exception process in here. I don't know. So, but this is something that the Standards Advisory Committee will be voting on next Thursday. I think it's Thursday or Wednesday. But anyway, next week. And that recommendation will be going to the actual commission. So any other member ideas or thoughts, concerns about this?
I do not see anything else. Was the next slide just questions now? Okay.
Right. So Phyllis, do you have anything else you want to add before we sign off for today?
Nope, I'm good. Thanks. Appreciate the opportunity.
All right. Right. Well, I think I'll turn it over to Blake to do some of his final stuff. I thank everybody for hanging in there and listening. And as always, you can shoot questions or issues to us via our individual email address or safeandcalm@leadingagemi.org. Thank you.
So we have,
go for it, Blake.
All right, so we have all those emails up right here. So if you want any of those, you can feel free to grab those really fast. And like Deanna said, we will be sending out everything later. So those you'll have that PowerPoint and you'll have all that information coming to you later as well. We would like to just say thank you to the rest of our exhibitors as well. Obviously, if, like I said earlier, if you do get a chance to support their programs and their services, please do. They mean a huge deal to us. And then lastly, we would just like to thank Deanna and Dalton and Phyllis all for joining us today. And we would also like to thank our members. I believe we had up near 60, a little over 60 participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything that you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we will be moving on to COVID-19 webinar again, this format Wednesday and Friday next week as well. So I think that takes care of everything, and have a great day and a great weekend, everyone.